and the next door classroom doesn't have an entrance from that hallway, so you're gonna have to come around this hallway, okay? And it's just next to, it's 219, so it's next door just.
Oh. I was like, I feel like no one's here. It's like, I'm missing.
Okay. So who was doing their presentations yesterday? Or Tuesday? How did it go? Brain mats. So the most common, what is the most common malignant tumor in the brain?
I know it.
Yeah. And? No. It's a kind of trick question.
Something.
Pardon? Metastatic. So this is why I mentioned that last week. If somebody asks you what is the most common primary brain tumor, then it would be glioblastoma multiforme, or GBM. If somebody says to you, what is the most common malignant brain tumor, then it's metastasis. Okay. Same as if somebody asks you, what is the most common bone tumor? Metastatic, yeah, metastatic bone. So, and that's something that will come up in tests and exams, so read the question carefully. Okay, so let's see if my beastie will work today. Let's help if you hit the button. It's coming. It's just taking its own sweet time and getting there. Okay. So what's the difference between, give me a guess, what's the difference between treating someone for brain mets and treating someone for a malignant primary tumor? Anybody care to guess? Anybody?
Isn't brain mets like?
Pardon?
Isn't it like brain mets is like a primary tumor is that tumor that you're treating,
Mm-hmm.
and then the brain mets is all over.
Most of the time, yeah. Most of the time it is, yeah. So brain mets basically, it can come in single little tumors, but the majority of the time there's a lot of them.
Mm-hmm.
So instead of just doing one area, you do the whole brain. So this is just the thing for, okay.
What?
Sorry. So 10 to 40% of adults with cancer. Most common form of brain tumor. In adults, 10 times more common than primary tumors. It's very common. It has very much a disabling effect depending on what area of the brain is involved. So it could be change in personality. It could be memory, either long-term or short-term memory loss. They may not be able to use language very well. Does anybody know the name for someone who cannot actually speak, cannot actually form words and talk?
Mute?
No, no, yeah, that is true. However,
As
what
far as
I'm
this?
looking for is a result of a disease.
Okay.
It's called aphasia. Aphasia. And that is what, if you hear somebody saying that so-and-so is aphasic, it means that they know how to say it, but they just can't get it out. And of course, mobility. You'll find people who have difficulty walking, or if they can walk, they can't walk in a straight line, they sort of bounce off the walls because they're not sure about where the perception of distance is off. And obviously, if you have somebody whose personality has changed, it makes a terrible difference to the patient and his family or her family. They're used to having someone who is mild-mannered and will do anything you want them to do, and then you have somebody with this brain tumor who yells at everybody, gets angry, is violent, things like that. May not know who the person is. Okay, so types. So brain mets is more common in lung, breast, melanoma, and what they call unknown primary. And it is somewhat rare in esophagus, oropharynx, non-melanoma skin cancer, and prostate. You very rarely get prostate going to the brain. It goes to the bladder, it goes to the spine, but very rarely goes to the brain. And look at this, 50% of all lung cancers will end up having brain mets. And which is the most common lung cancer that goes to brain? Anybody remember?
Small cell.
Small cell, yeah, small cell. So here is, this is 2004, so it's a little behind the times, but it gives you an idea. So this is the total number. This is the number of single brain met. This is the number of multiple brain mets. So you can see that this is non-small cell lung cancer. This is breast. This is small cell lung cancer. Melanoma, renal, gastrointestinal, gynae or uterine vulvar, unknown primary, ovarian, bladder, prostate, testicular, miscellaneous. So it runs the gamut. So, presentation. Headache, 40 to 50% of patients that have brain mets have a headache. And it says worse when bending or straining. Seizures. Again, it depends on where the tumor is or where the tumors are. CVA symptoms, 5 to 10%. What's CVA? Which is what? A stroke. Yeah, CVA is cerebrovascular accident, stroke. Focal neurologic dysfunction. What do you think that means? Focal neurologic dysfunction. What does focal mean? Anybody? What does focal mean? Focal
Like a
means,
specific spot.
yeah, it's in one area. And neurologic. Yeah.
Brain.
Yeah, brain or spinal cord. And dysfunction, obviously, it means that they're not functioning well. So what this actually means is that you've got some part of the brain or the spine, just one little piece, is not functioning as normal. So it could be that patients having difficulty hearing, which is part of the brain. Once you get in, patient may have problems with double vision, which means that the orbit may be, or the orbital nerves may be involved. Or he's lost his memory. Or he can't talk. And cognitive dysfunction. It's cognitive. Anybody? Thinking, yeah. So they may be able to, they know what they want to say, but they can't get the brain to work it out.
It's frustrating.
Yeah, it is frustrating. And you can see them getting frustrated.
Mm-hmm.
Okay, so signs of brain metastasis in 392 patients. So altered mental status, you've got 139 patients, which was 35%. Hemiparesis. Hemiparesis,
Half.
which we have.
Oh God.
Is it half this way? Like paraplegia?
No.
So what is it?
This way.
Yeah, like a stroke.
Yeah.
So it's basically you're paralyzed down to one side, like a stroke. Hemisensory loss. So you may have hearing and eyesight problems on the one side. And normally it's the opposite side from where the tumor is. So if you have a tumor on the left-hand side, normally the sensory loss is on the right-hand side. So it's sort of backwards. So that's what you know. Papilledema. Papilledema.
Reddening of. Is it reddening?
Reddening?
Or no. Yeah, swelling. Sorry.
Swelling, okay. And what's the papilla part of it? Pardon?
I was thinking the eye. I was just scared to say it.
Why?
I don't know. Because I was just wrong.
You know, if you think about it, probably somebody else is thinking about it as well.
I just said the wrong thing. I was thinking.
Don't worry about it.
I was thinking swelling, but I said
No.
reddening.
Yeah.
Oh, I guess I should get out of her spot now.
I can receive one for you.
Yeah. Do you know where you're going, dear?
Yes, ma'am.
Okay. Down to the chief's office. You know where that is?
Yeah, on the first floor security.
Huh?
First floor security.
No. It's in C building.
Okay.
You know where the auditorium is? Go out. Oh, let me go down and see. Read your books for 5 minutes.
I'm sorry.
Damn it. Suddenly realized coming up the hallway here. What do you guys think of the directed reading thing?
It was cool.
It was good.
It's cool, isn't it?
Yeah.
Remember that when you're trying to get your 24 credits every 2 years.
So how many credits would that be?
I think that one's only 2.
That's 2 credits?
I'm not sure, I can't remember. I'll have to look at it.
You know, it wasn't too bad. It's like the answers are in order in the text.
Yeah,
So,
yeah.
as long as you read it, just keep going back.
That's what most people do, and I must admit I do it too. You look at the answer, the first question, and you think, okay, that's at the start, so you look at it, and you think, okay, that's it, and then you highlight it just so that you know where you're sitting, and you go down like that. That's how most of us do it. Okay, so we did papilloma. What is gait ataxia? Gait ataxia.
Go ahead.
What?
Dysfunction of the cerebellum.
So movement.
Movement. What kind of movement?
Walking.
The way you walk.
Walking, yeah. So sometimes, think drunk man,
I don't know where.
you know, they're sort of going like this. Or sometimes it's difficult for them to even walk. So that's what gait ataxia is. So 53% of brain tumors are single, which means colon, breast, thyroid, lung, and renal. And 47% are multiple, which usually is from small cell and melanoma. The problem is that small cell is by far the most common type of brain met to get. So the majority of the brain mets are multiple. So, prognosis. Untreated, you get basically a month.
Oh no.
Patient has it. If they do steroids alone, which steroid would it be?
Prednisone.
Pardon?
Prednisone.
No. You remember about Decadron
Oh yeah.
or dexamethasone? Same thing. Yeah, Decadron is usually the one that we use, and the majority of patients well, actually all patients who have got tumors in the brain and or spine will be placed on Decadron.
Yeah, I was thinking that was for spine, but I didn't know it was for both.
Well, yeah, so the reason why we do that is if you consider that both the brain and the spine, tumors there will be a space-occupying lesion. The brain is tucked away in the skull. There is no room to swell. If they swell, you get these intracranial pressure. And the symptoms of intracranial pressure are nausea, vomiting, dizziness, gait ataxia, and headaches. Did I say headaches before? Okay. So with treatment, with radiation, 3 to 6 months. Sometimes they'll be well enough to have surgery. They're not going to go in and do surgery if you have multiple metastases. If you have a single metastasis, the surgeons may try and go in and get it out. But then they'll turn them on and give them to us for radiation. And that is basically 10 to 16 months if you're lucky, or if the patient's lucky. And so overall, 1 year survival is approximately 10%. So once they have brain mets, you're basically trying hard to keep them alive for a couple more months. It's unfortunate and it's very sad, but that's the problem. So, KPS. Anybody know what KPS is? It's in your book.
Isn't it the Karnofsky? Is that what it is?
Almost, try again.
Karnofsky performance scale.
That's it. So, page 617. Karnofsky performance scale. So, if you look at this, all of us here, hopefully, are 100. So if the patient's walking and talking and is able to go ahead with his activities or her activities, then they're 100. If you look down, so better prognosis if you have a Karnofsky performance scale of 70 or greater than 70. So if you look at 70, it says unable to work, able to live at home, and care for the most personal needs. And then it says self-care, inability to carry on activity or do active work. So if you're above that, say you're 80, which means normal activity with effort, some signs or symptoms of disease. So if you're above 70, you have a better prognosis than if you have below 70. 0 is dead. And just to confuse you, below that, you have the ECOG scale, which is Eastern Cooperative Oncology Group. In this case, 0 is fully active, 5 is dead. But the majority of us here in the US use a Karnofsky scale. So 70 and above is a good prognosis. If the primary tumor is controlled, you have a better prognosis. So for example, if you have a patient with brain mets from breast cancer, and the breast cancer is under control, then the person with brain mets from that particular breast cancer has got a better prognosis than the other person whose cancer, his primary cancer, is not under control. No other sites of metastasis, so the only site that we know of is the brain, then they have a better prognosis. Whereas if the same breast cancer patient has got spinal mets and brain mets, they have a poorer prognosis. And age less than 65 has a better prognosis. So treatment goals. Basically, you want to keep the patient alive with a good You know that they're never going to have a good quantity of life, but you want to give them as good a quality of life as is humanly possible. So, prevent or relieve neurologic symptoms. So you want to keep them as well as can be expected with a brain tumor. They may not be able to see very well, but if you can get them to go get around with help, at least that's something. Extend life, obviously, but you have to extend life with a good quality of life. There's no good in somebody hanging on if they're basically stuck in bed all day on painkillers and they're confined to the bed. That's not a good quality of life. We want them to get at least up and moving and take part in some type of life. Improve the quality of the remaining life. And maybe cure. That's a big. It doesn't happen very often. You can extend it, but it doesn't happen very often. So, therapeutic options. The patient has a widespread systemic disease, they may decide for no treatment. Go into hospice, perhaps, and no treatment. No curative treatment, no actual medical treatment. Emergency treatment to correct life-threatening complications. For example, hydrocephalus, hemorrhage, herniation. We know what hydrocephalus is, don't we? What is hydrocephalus? Water. What's the water?
Spinal fluid.
Say again? Cerebrospinal fluid, yeah. Impending herniation. What's a hernia? Yeah, it's a bulge into usually the tissue, surrounding tissue. How could you manage that with the brain? Where would it herniate to? Where's the only opening? If you think about the brain, and no, actually not. Where's the easiest way to get brain out? Where would you think? Where does the spinal cord come out of? The foramen. At the base of the spine, or the base of the skull. That's where the brain would come out, it would swell and it would come out. And I think that's a surgical fix. I don't think anything else can be done on that one. And of course, hemorrhage. If you have a bleed in the brain, what's that? That's a stroke. And other treatment strategies, so steroids, surgery, and radiation. And as I said before, every patient who has a tumor of the brain and or the spine is put on steroids immediately. As it says here, rapid improvement within 6 to 24 hours, maximum effect for 3 to 7 days, but the benefit is temporary. That's why we have to do something else. So most common dose of dexamethasone, which is Decadron to everybody else, is 4 milligrams QID. What's QID?
4 times a day.
4 times a day. Doses as low as 4 milligrams QD, if not symptomatic. What's QD?
Every 4 days?
Every 4 days?
Every other day?
Every other day? No.
QD?
Every day.
QD.
QD.
Okay.
Every other day would be QOD. And up to 100 milligrams per day if symptoms are progressing. So there's lots of different, you can't really tell what dose you have to give to somebody with brain swelling or tumor in the brain, because they differ. Every patient is different. And taper as tolerated. So what they do is, say we have this patient on and they've got 4 milligrams QID, 4 times a day. They get 4 milligrams 4 times a day. And they've been on it for a week or so, and they're starting to feel better. Does anybody know the side effects from steroids? Any steroid? Has anybody ever been on steroids?
You get hungry.
You get very hungry, yeah. So you put on weight. Anything else?
Some people that have like aggression and anxiety.
That's roid rage, yeah, that doesn't happen unless you're really getting high doses.
My child was super hyperactive. He was on them for like 10 days.
Mm-hmm.
Spun at the top.
Yeah, yeah. The other thing is that they get what's called moon face. Their faces get round and they look as if, yeah. And that's part of the side effects, and that and massive hunger. So the problem with steroids is that you don't stop them immediately. You have to taper them off. So you go on to steroids because of what they call the intracranial pressure. And it's intracranial swelling that's causing the pressure. So they put them on steroids, say 4 milligrams 4 times a day. And then they feel better. They're eating like a pig, but they feel better. So the doctor, okay, let's taper it off. So instead of 4 milligrams QID, they may decide to do 4 milligrams TID, which of course is 3 times a day, for a couple of days. And they start to get headaches. So they pump them back up to 4 milligrams QID for a couple more days, and then they start trying to taper off again. And that's how they do it. And it is tapered until or unless the side effects are there. Then they pump it up again. So it could be weeks before the patient can get off the steroids.
But, I mean, if you're looking at like a 2-month life expectancy, why even worry about taking them off? Why not just leave them on?
Because there are other side effects, again, like if you're on it for a long period of time, they can alter their personality, like the roid rage that you get with these guys that use it for bodybuilding, you know? So yeah, it can cause more harm than good if they're on for a long period of time. Okay. So, choice of therapy. So, location, size, and number of brain mets. Extent of systemic cancer. So, you have the patient who has got lung cancer. He has spinal mets and he has brain mets. what do we treat first? His lung isn't giving him any problems. He's a little breathless, but it's not giving him any problems. His brain mets is making him feel as if he's drunk because he can't walk in a straight line and he's forgetting things and he's being angry with his wife. The spinal mets, he's got a sore back. What do you think we start with? The brain. Yeah. We start with whichever cancer, whichever lesion is causing him the most problem. So if he couldn't breathe, for example, then we treat the lung and perhaps the brain as well. We can do them both together. The same, not together, but at the same time. So we treat his brain, we treat his lung, and then we treat his brain on the same day. Patient age.
You would do that at the same, you wouldn't do that immediately at one after the other?
Yeah.
You would? Okay.
Yeah. So what we would do is we'd get him in position for the lung, so his hands would be up on the wingboard. We'd treat APPA, and then we'd finish that, we'd take the wingboard off, put the head base on, put the mask on, treat that. So, patient age, performance scale, and neurological status. So it depends on how the patient's general condition is. If the patient wasn't well, his age was 80 something or 75 and he wasn't doing well, his performance score was something like 60, the surgeons won't touch him. So we do radiation. Type of tumor and responsiveness to therapy. If the primary tumor is radioresistant, that would mean that the brain metastasis is radioresistant also. So in the rare cases where you would get a radioresistant tumor, for example, liver, which went to brain. Liver cancers are radioresistant. Therefore, it's the same cancer, it's just in a different spot. So that would be radioresistant as well. So they may try chemo, and then if the patient is not too badly off as far as general condition, they may do surgery for the brain met. May do surgery for the liver met as well, or the liver primary. So, surgery, radiotherapy, stereotactic radiosurgery, chemotherapy, hormonal and targeted therapy. Targeted therapy is an immunotherapy, and the monoclonal antibody stuff. That works well with melanomas. Chemotherapy will work well for the primary tumors, but normally not for the brain mets. Does anybody remember what stereotactic radiosurgery was? It was on one of the quizzes. Anybody? Stereotactic radiosurgery is treatment to the brain always. Large dose, small volume, one treatment. So you give a huge dose to a very small area in one treatment. No margin for error. You have to get it right the first time, because that's the only time you get.
Is that the CyberKnife or is that different?
CyberKnife is part. CyberKnife can do stereotactic radiosurgery, but that's only one type.
Why do they call it, what's the stereo?
Stereotactic, it means that you are in place, and usually it's like a halo device where, and you'll, I've got a video of it, you will see the patient and they have this halo and they've got screws attached to the skull, through the front, through the back, and they put this halo device on. The halo device attaches to the bed and the patient cannot move. That's partly why it's only one treatment. And that can be done either with CyberKnife, with Gamma knife, or with a normal linear accelerator. So, stereotactic solitary brain mets, that's probably the one that you would choose to do stereotactic on. SRS is what it's called. So, an MRI should be done to look for the presence of occult mets. So if you have solitary brain mets, one solitary brain metastasis you see, the MRI is done. What does it mean for occult mets? What do you think that means?
Hidden.
Hidden, yeah. So you see one, but is there any others hiding somewhere? That's why the MRI. It shows up brain mets very well, much better than for CT. And the MRI with contrast can detect a lesion as small as 1.9 millimeters. Teeny, teeny tiny. And if you only have one metastasis, which is in the region of 2, maybe 2.5 millimeters, you can treat that with stereotactic. The biggest that most people will treat with stereotactic radiosurgery is 2 centimeters.
I feel like with brain mets, wouldn't it, I mean, even if you've only got one that's visible by MRI, aren't there probably other?
There could be, and that's why a lot of patients will get whole brain radiation first, and then if they find another one, then they'll do an SRS. So differential diagnosis, primary brain tumors, infarcts, cerebral abscesses, hemorrhages, and demyelinating disease. So cancer patients with single lesions had 11% had lesions other than metastasis. Half were primary brain tumors, half were infections. So just because you see one tumor, it doesn't mean to say that that's the only. It could be an abscess, it could be a hemorrhage, it could be a benign condition, it could be an infarct. So, but if the patient has got a history of cancer, then 99 times out of 100, it's brain met. So surgery followed by whole brain. So they found one brain met. They do surgery to take it out. Then they'll do whole brain radiation therapy, just to make sure there's nothing else hiding. So randomized trials, so this is surgery plus radiation versus just radiation. So surgery plus XRT, 50 weeks versus 40 weeks. 6 months versus 10 months. 5.5 months versus 6.25 months. This one doesn't have much difference. This one, however, yeah. And this one definitely.
So you're saying the surgery versus just radiation whole head?
So surgery and radiation versus just radiation alone. And it depends on what, it depends on what type of metastasis it is. Is it a large one or is it a very small one? Or have they they have tried and made sure that there's nothing else there? These randomized trials, sometimes it's like statistics. You can make them show what you want them to show. So result of surgery for solitary mets. So 118 patients with melanoma. So 50% had neurologic improvement, 19% had no change, and 22% experienced worsening in neurologic symptoms after surgery. Median survival, 8.5 months. So you know that you're gonna have 6 months without any treatment at all. 4 to 6 months. So you're going in for surgery, that would be brain surgery, for another 4 months. You have to decide whether it's worth it. Or usually it's the family that has to decide whether it's worth it. So stereotactic radiosurgery, linear accelerators, gamma knife, protons, or this is intensity modulated radiotherapy. So you basically have linear accelerators, protons, or gamma knife. That's your 3 choices. The gamma knife uses cobalt beams, protons, or linear accelerators. They're all the same. Well, they all do the same thing, just a different way. So you have, well, here they're saying 3 centimeters or less. So stereotactic, large doses, very small volumes, 1 treatment. So good for radio-resistant cancers, 3 centimeters or less. And we're talking sometimes 3,500 centigrade in 1 fraction to a very small dose, a very small tumor. And if you have 3 centimeter tumor, that's the amount that you treat. There is no margin for error. There is no area surrounding it for patient movement or difficulty in setup. Can be used in surgically inaccessible areas of the brain, for example, the brain stem. No surgeon is going to go in and figure and try and get something out from the brain stem. Because if you have a tumor in the brainstem, what happens if you accidentally do something to the brainstem? What happens to the patient?
To die.
He dies, yeah. Non-invasive procedure, almost. It can be used for up to, I don't think so. It says here it can be used for multiple brain mets up to 6. No radiation therapy, no radiation oncologist I've ever worked with would do 6 brain mets altogether. They would do a maximum of 3. And then they would bring the patient back for another 3. They would never do 6 altogether because it takes too long. Your patient is, if you're doing the halo, the patient comes in, gets the halo put on by the neurosurgeons first thing in the morning. The CT is done immediately after. Then they sit and wait for maybe 5 or 6 hours till the machine is ready for them. And then it takes about an hour to treat with 2 or 3 meds. Nobody's gonna do 6. So tumor control rate, 70 to 96%. Median survival, 7 to 12 months. Excellent improvement in quality of life with little morbidity. So it works very well. So, SRS versus neurosurgery. Stereotactic radiosurgery, no hospitalization, done as an outpatient procedure, albeit that you're in the department all day. Lower risk of tumor seeding, hemorrhage, or infection. Because once the surgeon gets his knife into the brain, they can seed, the tumor can seed. Everybody know what I mean by seed? It can spread. Immediately relieves mass effect. You can get a pathologic diagnosis. They can actually tell you what type it is. Whereas in stereotactic radiosurgery, there may be no pathology. And of course, no radiation necrosis. Neurosurgery versus radiosurgery. So the radiosurgery is in the blue. The normal surgery is in the black. So you can see that it's lower, but it lasts a lot longer. This is years. So, primary cancer, lung patients with solitary brain mets. Resection of the brain met alone, 2% 1-year survival. Resection of brain met and lung lesion, 50% 1-year survival. So if they take out the lung tumor and they also take out the brain met, then it jumps from 2% to 50%. Obran radiation. Multiple brain mets. I don't think anybody would suggest that they would go in and do surgery for multiple brain mets, to be honest. They'd probably just do whole brain. So usual, 30 gray in 10 fractions over 2 weeks. And sometimes 20 gray in 20 fractions, no. I would say probably 40 gray and 20 fractions, but that's a little much for patients. Response rate 50 to 85%, and it does relieve symptoms. But it takes a while to actually start taking effect. So, brain atrophy, it can happen. Radiation necrosis, hydrocephalus, neuroendocrine dysfunction, worse with combined chemo, and worse with larger fractions radiation therapy. Blood-brain barrier. Brain is a sanctuary site for medications. Everybody heard the blood-brain barrier? Yeah. They have got chemo now that cross the blood-brain barrier, but not very many. Enhancing lesions on scans indicate disruption of the blood-brain barrier, and micrometastasis can go in there. Phase 2 studies. That is resection of the brain tumors. Depends on chemosensitivity, and hormonal therapy may also work. And those are the ones that can now go past the blood-brain barrier. Gliadel wafers, I think I mentioned that last week. So the wafers that go in they actually put them in the brain. An I-125 solution. Seizures. Presenting symptom in 10 to 20%. They may occur later. Frequency of seizures, same in patients with and without prophylaxis. So anticonvulsant therapy is not usually recommended unless the patient is seizing. And the anti-seizure medication that we use most commonly is something called Dilantin. There we go. Rashes, erythema. Can't remember what this one is. Stimulation of the hepatic clonodrome, so the enzyme system, and accelerates the metabolism of some chemotherapy agents. Paclitaxel. Cyclophosphamide, doxorubicin, ifosfamide, and vinblastine. Paclitaxel is actually an interesting drug. Actually, Taxol drugs. Taxol is actually from the yew tree. Y-E-W. Everybody know what a yew tree looks like? No. So some bright, I'm not sure how it managed to get there, but some bright spark was looking into medications that could be brought from nature. And the leaves of the yew tree, it's been known for years that they're poisonous. So they thought, well, let's try. So they got some stuff from the yew leaves and tried it on animals first, of course, and then on humans, and it works. It's a chemotherapy agent. So Taxol is the root, and then you have all these different Taxols, including paclitaxel, but they're all from Taxol, which is from the yew tree. It's the useless piece of information. Recurrent disease, repeat irradiation. So if you've had whole brain radiation, you could try stereotactic. If you've had stereotactic, then you could try the whole brain. It's probably not a good idea to repeat the whole brain tumor, the whole brain radiation. Prophylactic cranial irradiation is a standard of care in limited stage patients with small cell lung cancer disease, the disease remission. So, cumulative incidence of brain mets with small cell is approximately 50%, but it is reduced in half with PCI, prophylactic cranial irradiation. Okay. Patient is a 47-year-old man who was found to have a lung mass on screening, chest x-ray in February 2003. He underwent right upper lobectomy. Pathology showed a T2N1M0, poorly differentiated small cell carcinoma. In July of 2003, the patient developed aphasia and had a seizure. He was found to have a mass in the left frontal lobe. The mass was resected and was followed by whole brain radiation of 3000 centigrade. The patient was asymptomatic. His last seizure was approximately July, and the previous seizure was 6 months before that. He asked about resuming driving. What would you tell him? Think about this. We don't want the answers yet. Think about that one. Okay. Number 2. Patient is a 58-year-old heavy smoker who underwent resection of a lung adenocarcinoma in January 2004. He did well and returned to work full-time as a long-distance truck driver. In June, he presented with complaints of right-sided headache and unsteady gait for 10 days. CT brain revealed multiple brain lesions consistent with metastasis. He was treated with brain radiotherapy and with resolution of his CNS symptoms. You can see it there. There's also a couple of little ones here and here and here. Can he go back to work now? So here's one, here's one, here's one, here, here. This one's the same as this one. There's one there, there's one there. Okay, that's number 2. 3. Patient is 71-year-old diagnosed with non-small cell, February 2004, with liver and lymph node metastasis. He improved on chemo but stopped due to side effects. When evaluated at the VA, he stated that he had been walking 3 to 4 miles a day, but recently was having more difficulty and having frequent headaches. Brain CT was ordered. His gait was ataxic, and he staggered into the examination room. He refused admission, and plans were made to administer brain radiotherapy as an outpatient. He had driven himself to the clinic appointment with no problem and was by himself. He wanted to drive himself home. Would you let him? So, here, 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 and there's probably a little one there, and there's a little one there, and there's a little one there. Okay, so, driving and brain tumors. This varies by state, by the way. Person shall not drive a commercial vehicle unless he or she is physically qualified to do so. Does not have any certain specified impairments to driving. Which are the impairments to driving? Epilepsy, mental, nervous, or psychological disorder. So this is in Texas. So this is commercial driving. No clinical history of epilepsy. Laws are different in each country and laws are different in each state. In the UK, solitary seizure, 1 year, epilepsy, 7 years after last seizure for personal car. In Texas, persons with epilepsy must be certified seizure-free for a period of 6 months before they can be licensed to drive a personal vehicle. Physician licensed to practice medicine in Texas may voluntarily inform the Department of Motor Vehicles, I guess it would be, about an impaired patient. The release of such information is an exception to the patient-physician privilege. Physicians may not be held liable for the professional opinions or recommendations. So, case number 1, solitary brain met resected, seizure-free for 4 months. Can drive his own car, no seizure for 6 months, neurologically able and no recurrence. So he can drive. The truck driver, unfortunately, no. With multiple brain mets and good symptomatic response to radiotherapy, he cannot be a commercial truck driver anymore. Anybody guess about the number 3? Multiple brain mets. It's wanting to drive himself home from the clinic. Short and sweet, right? No. The doc should not let him. About 40% of patients with brain mets will die because of the metastasis themselves. For most patients, survival depends on the extent of cancer outside of the brain. So surgery. In July 1999 for lung adenocarcinoma. February 2002, solitary mass in the right frontal lobe had craniotomy, followed by XRT, 3000 centigrade. Recurrence, November 2002, repeat craniotomy. So what's a craniotomy? Anybody?
Opening up the skull.
Yeah, opening up the skull. So patient number 5, surgery in 2002 for breast cancer. 2 brain mets resected in January and February. So with surgical resection or SRS or XRT, or SRS and XRT, significant palliation of symptoms and prolongation of life is possible. Aggressive measures should be considered in appropriate cases. So that's brain mets. And I think we deserve a break after that. So let's, exam is going to be not next week, but the week after. So in order to give you guys a reasonable review, I'm going to stop CNS here, and I'm going to go on to pediatrics. But we will continue with brain because we're going to start with pediatric brain. So, brain tumors in pediatrics. Oops. So this is for physicians. So you should be able to understand it most of the time. So 20 to 30% of all cancers in children are brain tumors. Second most common neoplasm in children. About approximately 3,000-ish new diagnoses a year. Most occur before the age of 10. And they're pretty evenly spaced, but there's more males than females just. 1.3 to 1. And approximately 70% 5-year survival. Which if you're 10 years old, it doesn't seem a lot, does it? But that's the average. So, brain tumors. So we have certain ones that you would see in adults, but most of them you would not. The craniopharyngioma, for example, you do tend to get a lot in adults, but certainly, definitely in children. Astrocytomas, you see in adults, you see also in children. High-grade astrocytomas, pineal tumors, cerebellar astrocytomas, which you don't often see in adults. Majority of the time, the astrocytomas are in the cerebrum, not in the cerebellum. Ependymomas, right? We saw those. And brainstem glioma. Medulloblastoma is actually, believe it or not, the most common tumor, CNS tumor in children. Medulloblastoma is one of the few brain tumors that will spread down the CSF. So you wouldn't be treating just the brain, you'd be treating the whole of the central nervous system. So you would treat down the spinal cord. And I see people are looking, and I'm just going to, so it's chapter 35. You want to follow along? What do you think is the most common childhood cancer? Leukemia. What type of leukemia? Pardon? ALL. Yeah. So what are the 4 types? There's ALL, which is acute lymphocytic leukemia or lymphoblastic leukemia, whichever way you want to look at it. So what's the other acute? There are 2 acutes. Sorry?
AML,
AML, which is what?
acute myelocytic.
Or myeloid leukemia. It's a lot easier to say. Next one. So there's 2 chronic leukemias. There's 2 acute and there's 2 chronic. You just given me 2. The other 2 are not that far away from what you've just told me. Yeah, chronic lymphoblastic leukemia and chronic myeloid leukemia. So if you can remember one, you can remember the others. Okay, but we're not doing that at the moment, so we're still on brain. So, brain tumors, 5-year survival by age. So here is the children, 0 to 20, 21 to 64, over 65, which is actually abysmal, and overall. So this is up to the end of 1999, 1998. So what age do pediatrics stop at? You're still a pediatric patient until you're the age of what? 18, yeah. Mind you, an 18-year-old would not be happy if you call them a pediatric patient. But, sorry, them the breaks. So supratentorial and infratentorial. So you see, this one is Unfortunately, there's not a real lot of difference in that one. There's more, so what does infratentoral and supratentoral mean? I think we went over that last time. What's the difference?
About that line between the
Mhm.
cerebral and infratemporal is below that.
So the infratentoral is usually the cerebellum, and the supratentoral is usually the cerebrum. So the majority of the adult patients are supratentoral. The majority of the children are infratentoral. So here is the astrocytoma. This is supratentoral. Astrocytoma, ependymoma, mixed glioma, glioglioma, ganglioglioma, oligodendroglioma. That's what you were trying to say last time, right? PNET, I'll get to that in a sec. Choroid plexus, meningioma, germ cell tumors, and others. Here's the infratentoral. So the medulloblastoma, the astrocytoma low grade, the ependymoma, the brainstem glioma, high grade, the brainstem glioma low grade, and the others. So this is, so it's 45 to 60% in children, infratentoral. And the most common one there is definitely the medulloblastoma. So, signs and symptoms. What are the signs and symptoms of brain tumors? Oh, let me write them down. Okay, signs and symptoms of brain tumor or intracranial pressure. Signs and symptoms.
Headache.
Okay.
Vomiting.
Nausea and vomiting. What else? Unsteady gait. Uh-huh. Cognitive problems, shall we say? Uh-huh, okay. Give you one. Double vision. What else? Okay, let's see. Headache, nausea and vomiting, double vision, head tilt. So if you sort of do this or do this, the headache or the nausea and vomiting gets worse. Decreased alertness, lethargy or irritability, poor feeding, don't eat well, especially in children. You know, most kids will eat most of the time. Endocrine dysfunction and unexplained behavior changes. So that would include the gait, the cognitive problems, and the aphasia. So, increased, continued, papilledema, loss of vision, increased head circumference. How the heck do you get an increased head circumference? Swelling. Or hydrocephalus, increases the head circumference. Bulging fontanelles, spreading sutures, increased blood pressure, low pulse, herniation, setting sun sign. Anybody ever heard of that one?
Is that the same as sundowning?
Kind of. It gets worse as the day goes on. So posterior fossa, primary. So we have ataxia, tremors, dysphagia, stiff neck, and papilledema. And if we've got a brainstem, primary, extreme extremity weakness, cranial nerve signs, so double vision, facial weakness, swallowing, and dysfunction. Hemiparesis, hemiopis, hemaniopisa, aphasia,
Hemianopsia.
pardon?
Hemianopsia.
Whatever.
Hemianopsia.
And seizures.
Would be a pro.
Yeah.
Pronunciation.
Okay, so medulla. So how are we treating these guys? Medulloblastoma, which is actually a posterior fossa tumor. Surgery, craniospinal irradiation, and chemo. Low-grade astrocytoma, surgery, treat small area, no chemo. Cerebellar astrocytoma, surgery, perhaps radiation, no chemo. Optic glioma, no surgery, could have radiation, could have chemo. High-grade astrocytoma, GBM, which is what? GBM? Glioblastoma multiforme, yes. So surgery, yes, if you can get it. Radiation, yes, no chemo. Brainstem glioma, different. No surgery. Small field treatment, probably no chemo. Ependymoma, surgery and treatment, no chemo. Germ cell tumor, the only thing to do would be a biopsy. The treatment, radiation and chemo. In general, we need diagnosis for surgery. IV is gross total resection. You have to balance the prognosis versus the morbidity. What's the difference between morbidity and mortality? Or let's put it this way, what is morbidity? Anybody know what morbidity is?
Is the symptoms or the?
Not the symptoms, not the symptoms of the disease, no. It's the reaction of the patient's body to the treatment. So, for example, if you have morbidity is usually on a scale of 1, 2, 3, 4. If you have, for example, a rectum and there is a morbidity scale of 1. That usually means that the patient is having moderate diarrhea, which is controlled. If, however, you have a morbidity scale of 4, it means that they have uncontrolled diarrhea. It may have to be surgically treated. Or there is a problem with the colon or the gut. There is a problem that needs to be surgically fixed. That would be a morbidity scale of 4. So it goes usually from 1 to 4. So that would be your morbidity scale. So if, for example, the surgery is going to make the prognosis better, but it would make the patient feel worse. So the old saying about the surgeons, we cured the disease but the patient died. So you have to balance those two. So debulking shunts and reservoirs for symptoms of intracranial pressure reduction and therapy. So the surgeons go in and they try to debulk the tumor, which means it makes it smaller so that the radiation can come along and treat a smaller tumor. Put a shunt in. Everybody know what a shunt is? Everybody at least heard of a shunt? It relieves the pressure usually. And the reservoir would be if they're having problems with the cerebrospinal fluid. They may put a shunt in to make a reservoir for the CSF so that it doesn't expand to hydrocephalus. Potential for use in all brain tumors, surgery, and radiation therapy. So craniospinal treatment, exceptions, okay, so potential use in all brain tumors, however, choroid plexus tumors, it doesn't really help that much. But for everything else, radiation therapy usually can be done. Says neuroaxis prophylaxis. So craniospinal treatment. So if we have a medulloblastoma, which is the most common children's cranial tumor, we know that it can disseminate down the CSF. So the treatment for that is surgery to debulk, and then we treat the whole brain and the whole of the spinal cord. And then we go back and do a small field boost to the posterior fossa. Long-term effects, remember these are children we're talking about, right? So, neurocognitive. The patient probably is going to have a problem with the brain throughout the rest of the life. Hearing. It could be, depending on where the tumor is, it could be that they may have a problem with hearing. Again, endocrine problems, skeletal growth problems, and secondary cancers. Anytime you treat a child, the chances of them 30 years down the road having a second cancer, it has to be understood by the parents. You get this thing about, well, you have cancer and your child has cancer, we have to treat it. However, 30 years down the road, he may develop or she may develop a second tumor, second cancer. What would the normal parent do? Treat them. Yeah, because a lot can happen in 30 years, right? But if you don't treat them, the child's going to die. There's really no choice, but you have to tell them that anyway. If there is a choice, you can do nothing. Okay. Adjunct, so chemo, adjunct therapy in most cases. Medulloblastoma. Avoid or prolong XRT, so young children. Blood-brain barrier may be limiting, so you have to be careful about what you use. It may not pass the blood-brain barrier. So, medulloblastoma, pineoblastoma. So the medulloblastoma is the posterior fossa. Pineoblastoma is the pineal region, and the PNET, which is primitive neuroectic tumor, supratentorial. Median age for these tumors is about 5 years, 5-year-old. Some are younger, some are older, but the average age is 5. They tend to have a worse prognosis if they're older, a better prognosis if they're younger. Male to female, 2 to 1. A third of these patients will come in with metastatic disease at diagnosis. Medulla, prognosis factors. So age, the youngers do worse. I beg your pardon, I told you, right? So the younger tend to do worse. The extent of resection we have to watch out for. Most of these medullas are posterior fossa. The non-posterior fossa tumors do worse. Non-localized tumors tend to be worse. Makes sense. Standard risk is 70 to 80%, 5-year survival. And the high risk is 50%, 5-year survival. CSF dissemination. You have to make sure that the patient, before you start treatment, you have to make sure that the craniospinal fluid is not contaminated. So we do a spine and brain MRI and a lumbar puncture. It's very rare, but it can spread to lungs, liver, bone marrow, and bone, and lymph nodes. And the difference between supratentorial, PNET, and medulla and pineoblastoma is one is supratentorial, one is infratentorial. Ependymoma. This is another one that very rarely, but it does happen, spread down the CSF. Median age 3 to 4. It's only 10% of brain tumors of a child. Extent of resection, prognostic factors. Some reports they're saying that if they're older, they have a better survival, and it depends on the histology. Whoops, sorry. So if we have a resection, if the surgeons do a good job, and we've got a total resection, then we can get 75% 5-year survival. Less than that, it's about 30%. And radiation therapy does help. Chemo doesn't work. And unfortunately, if you have a recurrence, we can't do very much about it. Brainstem gliomas. Median survival, 6 to 9 months. Unfortunately, death within 2 years is 90%, greater than 90%. That's pontine gliomas. Low-grade gliomas, extramedullary. They're seen on the MRI, and they are indolent, which means they grow very slowly. This, let me put the lights off, you can see it better. This is the tumor. This is a lesion involving the pons. Low-grade astrocytoma, male to female, 2 to 1. Notice most of them are mostly males. Association with NF1. Anybody remember what NF stands for? Neurofibromatosis. It's a gene. NF1 is a more indolent course. And it is basically 90% 5-year survival, which is good. With radiation and chemo if they need it. Less than 3 years old. They're fun ones to deal with. Okay, so 60 to 70% of the children who are under 3 have tumors in the supratentorial. Unfortunately, the radiation with the 3-year-olds or under 3-year-olds can cause bad neurological deficits. Because after all, they're only 3 years old, their brains still growing. So we like to delay at least till they're 3 years old. We give them chemo. Not that chemo does any harm, I won't say it doesn't do any good, but it still causes side effects, but not quite as much as radiation before the age of 3. So there's a short course of 16 weeks chemo. That's what they call a short course, 16 weeks. And then we may do small field radiation and do what they call maintenance chemo. Neurologic effects. Limb paresis means that the limbs don't work too well. Rehab, PT or OT. Swallowing or speech malfunction. Speech therapy, nutrition. Neurocognitive deficits. Fortunately, school and education issues. Most of these kids aren't actually in school as yet because the majority of them are below 5 years old, so some of them are not. But if you do get the youngsters who are 7, 8, 9, 10, then obviously they're at school. And that can cause issues too because they fall behind because they have these cognitive difficulties. And endocrine dysfunction, which also causes problems with growing children. And organ damage, kidney, liver, hearing, and neuropathy. Oh. Actually, do the tests on these things. Okay. Let's do this one. This is actually- Okay, pediatric malignancies. They're actually rare-ish. 2% of all cancers. Most often occur before the age of 15. Majority of them we've seen usually around 10 or 12. Accounts for 10% of childhood deaths. Most common cause of death from disease, and it's only second to accidents. The most common cause of death in children is accidents. Cancer, unfortunately, is second. Leukemia, lymphoma, and CNS tumors are most common. %90 of children diagnosed with cancer are seen and treated in a COG-affiliated institute. COG is the pediatric, it used to be called POG, P-O-G, Childhood Oncology Group. They're research groups, and they usually work out of large centers. So the majority of children that we treat with cancer are treated in a larger center. So here in this area, we would probably be UF, Proton Center, UF Gainesville, Mayo, and MD Anderson. The smaller centers don't want to touch kids because they're difficult to work with. They really need specialized care. They really need a pediatric oncologist, a pediatric radiation oncologist. So the smaller centers don't want to touch them. They send them somewhere else. And I don't blame them actually, because it really is a subspecialty in radiation, is children. Overall survival is in the US is about 65 to about 75%, which is pretty good. So predisposing factors, syndromes, trisomy 21, bone marrow failure. So trisomy 21 is Down syndrome. Down syndrome is a predisposing factor for a lot of childhood cancers, including medulloblastoma. Hereditary, retinoblastoma, and Wilms tumors. Wilms tumor is a tumor of the kidney in children. Retinoblastoma is a tumor of, anybody care to guess?
Retina.
The retina in children. And that one is a familial one. It runs in families. And the average age of a retinoblastoma child is under 6 months old. And if you have one child in the family diagnosed with retinoblastoma, every succeeding child in that family for generations will be tested for retinoblastoma because it is a familial disease. And environmental, radiation and toxins. Age-adjusted incidence in US mortality rates for childhood cancers, under 20. All races, both sexes. So this is the incidence, this is the mortality. So there's your incidences going up and slightly down, and your mortality is going down. age-adjusted incidence, what was the other one? Age-adjusted incidence, all childhood cancers, okay. For childhood cancers by sex, age, and all races combined. So again, you have males, which are blue, and females, which are red. So you can see the difference. It's not that much different, except here it goes up and here it goes down. So, leukemia, lymphoma, so it's the average rate per million. So 37 per million of leukemia. Lymphoma, brain CNS, 25. Sympathetic nervous system is 7. Retinoblastoma, extremely rare, only 3. Renal is 6, which would be the Wilms tumor. Hepatic, extremely rare. Bone, soft tissue, germ cell, carcinomas, and others. So the most common is leukemia. The most common, apart from that, is brain. And lymphoma, you can actually get pediatric Hodgkin's disease. So here is leukemia per ethnicity. So leukemia is in green, lymphoma is in red, CNS is white, and others are blue. So you have white or Caucasian is 41.6, 24.7 lymphoma, 29.1 for CNS and others here. Black, 25.8, 18.7, 25, and 55. And American Indian is 24.8, 4, 10.9, and 39.9. So they're the lowest. And that is Asian Pacific Islander, I think is what that one is 41.2, 14.9, 19.9, and 60.8. So that is actually higher than the black. And then you've got Hispanic, which almost blows everybody else away except the Caucasians. So 48.5, which is actually more leukemias, 19.5 for lymphomas, 21.8 for CNS, and others. Interesting. So Caucasians are much more prevalent in most cases, but the Hispanic population, for some reason, I'm not sure why, are much more in with CNS. Childhood cancers by group, all races, both sexes. So acute myeloid leukemia, acute lymphoblastic leukemia, which is here, which makes sense. Brain CNS, lymphoma, and acute myeloid leukemia. So you can see the age range here. This is about 3 to 4 years old. Brain starts about that age too, and goes down as we get to the age of 20. And as lymphomas, as we get up to age 20, it increases because this is now in this area is counted adult as far as lymphoma is concerned. Neuroblastoma is tumors. Anybody care to guess what neuroblastoma is? So the retinoblastoma we know is the eye or the retina. The Wilms tumor I've already told you is the kidney. I should have left that one. And neuroblastoma.
Brain?
Pardon?
Brain?
Actually, no. Don't
It would be nerve, wouldn't it?
don't be upset. That's what everybody says.
I'm not.
Wouldn't it
It's
be nerves?
No. It's actually a misnomer. It is actually the adrenal glands. It's a pediatric tumor of the adrenal gland.
Don't like that.
Yeah, I know. So here's another one, hepatic, bone, soft tissue, and germ cell. So the hepatic is black, which is down here, way low here. And bone, which is here, and that would be the bony tumors like Ewing sarcoma. Soft tissue is the soft tissue sarcomas, which are the green. And the germ cell, which is real. So this is where seminomas come in. This is counted adult seminomas up here. So anybody over 18 years old would be able to have seminoma. Although it's not exactly done right. Ages 15 to 19, this one at the bottom. Oh, sorry, wrong one. So here is 15 to 19. So we have germ cell tumors, CNS, thyroid, medulla, ALL, AML, sarcoma, osteosarcoma, Ewing sarcoma, rhabdomyosarcoma, and other. Oh, and Hodgkin's disease. That's 15 to 19. However, let's look at below 5 years old. So we have AML, which is here, tiny little thing here. ALL, look at the numbers there. So that would be a bony sarcoma, hepatoblastoma, non-Hodgkin's lymphoma, rhabdomyosarcoma, germ cell tumor, other, retinoblastoma, Wilms tumor, neuroblastoma, and CNS. You see the difference in the distribution of the tumors from under 5 to 15 and over. So classically, peak incidence of leukemias, CNS, Wilms, and neuro are in the younger age group, lymphomas and bone tumors in the older age group. So things like bony sarcomas and small cells, soft tissue sarcomas are in the older group, and Hodgkin's disease are in the older group. But leukemias, CNS, and Wilms neuroblastoma are in the younger group. Overall, prognosis is good, 65 years old, or 65%, I'm sorry. Otherwise healthy patients. They may have CNS sensitivity and they may have growth issues. Consider this. If we are treating the kidney, which would be a Wilms tumor, we normally remove the kidney. right? That's the normal route, right? We remove the kidney, because it's so easy to remove. But we want to treat the kidney bed. So, if we have a patient, oops, that's not good, not meant to be there. And we have the kidney here. There, here's your kidney. So that is removed, okay? That's out of here. And we have the spine running down the center here. And of course, the spinal cord goes down the middle. So we've taken out the kidney, and the doctor wants us to treat the kidney bed. So normally, what would you do? You would do this, keep it away from the spine, and treat that area, right? This is the problem with children, which, lots of problems with children. But this is one of the problems when treating children. If we do this, then that's fine. But the dog wants us to treat this way. We're not going close to 4,500, so we're okay. What's that gonna cause in a growing child? If we treat right to the center of the spine, and this is a 5-year-old child, what's gonna happen when he starts growing?
It won't grow as normal.
Which part won't grow normally? The treated part, okay? So the spine, but only half the spine. So he'll end up like that. So this is one of the things this is the exception that proves a rule for these kids. So instead of doing half the spine, we would deliberately go over and treat the whole spine. So that when he grows, he may be smaller, but he's straighter. So he won't be like this. What's that called? Scoliosis, yeah. So he won't be scoliotic. He'll be straight. He might be small, but he'll be straight. Does that make sense? Yeah. So that's the kind of thing that you have to watch out for when you're doing children. That you know they're going to grow. So, long-term survivors. Second malignancies, we've talked about this. Well, so chemo and radiation, development and CNS function, cardiac, renal and pulmonary toxicity, and reproductive functions. So, if you're treating Hodgkin's disease, you remember we're treating a mantle. It's the same thing with a child. You treat the mantle. So the chances of a patient coming back in 30 years' time with a breast cancer, or a lung cancer, or if we're treating the thyroid, then we may have problems in that area as well. So the chances of them coming back with a second primary are significant, shall we say. because we're not only dealing with chemo and radiation, we've got CNS function. Even if they don't get a second primary, we're treating the whole brain of a growing child, so they're developmentally slow, shall we say. Cardiac, renal, and pulmonary toxicity. If we are treating the lung, we may have a problem with the heart. If we are treating the adrenals, we usually have to treat the kidney. And of course, we have reproductive problems. They may be sterile. You can't really have a child of 4 or 5 bank their sperm or bank their eggs. That's something, I know that sounds stupid, but you know, I've had parents ask me that, can we bank their eggs? No, they're 4 years old, for goodness sake. Yeah. But we make them sterile. And apart from everything else, good luck getting them health insurance in the future. You're a cancer survivor. Even if you grew up to, you had treatment at 10 years old, and you're 25 and you're looking for health insurance. It's gonna cost you. That's something that nobody thinks about. In general, these are all rare compared to adult malignancies, but venous access issues usually more difficult compared with adults. Yeah, you have to get the child to give you blood every couple of days. So what do? You put in a port, central line, and you send them to somewhere else to get the blood done. You don't do it in the department. We don't hurt people in the department. We send them to the bad chemotherapy people to get their blood done. Psychosocial aspects of treatment. Oh yeah. Some kids go through it with flying colors, don't even think about it. Others have problems. So, biopsy, definitive diagnosis. You have to have a diagnosis prior to treatment. 99% of the time, you have to have a diagnosis prior to treatment. Staging, local therapy, surgery, radiation, chemo. Chemo is not local therapy, it is whole body therapy. Chemotherapy for leukemias. Leukemias, we don't see a lot of in the department. The only time we see them is if their leukemia has spread to the brain. Then we would do some radiation to the brain. But we very rarely see leukemias unless we're doing a bone marrow transplant, which means that we have to give them whole body treatment. Combination chemo shown to be essential. Normally these days we don't give single drug chemo to anybody anymore. It's all combination chemo. So fluorouracil, methotrexate, metocarpurine, cyclophosphamide, azenophosphomide, carboplatin, cisplatin, doxorubicin, all of these treatments are given to these poor kids. Problem duration with therapy, these kids can be on therapy for 2 years, minimum. So they live on chemo, drug interaction and resistance. Okay, I think we've probably had enough today. What we'll do next week is we'll go over the first part of the morning. We'll continue with pediatrics, and then we will do some review of the rest of the stuff. Okay? So I would suggest you read chapter 35 and be prepared to answer questions. Okay? We'll see you back here at 1.
Thank you.